Okay, let's unpack this.
Right.
Today, we are strapping in for a deep dive that really demands absolute precision. Antepartum hemorrhage, or APH.
Yeah.
For anyone aiming for mastery in clinical practice, understanding APH isn't optional.
No, definitely not.
It's really the fundamental difference between, say, a managed challenge and a rapid onset catastrophe.
That is the core of it, exactly. APH is clinically defined as any bleeding from or into the genital tract after the 28th week of pregnancy, but crucially, before the birth of the baby.
And that 28-week mark.
Well, we use that 28-week mark because it's sort of the arbitrary lower limit of fetal viability, a point where intervention might save the baby.
Yeah.
APH occurs in about, 3% of hospital deliveries? And the stakes for both mother and fetus, they're truly the highest in obstetrics.
So our mission today is to really dissect the two major causes, Placenta Previa and Abruptio Placentae.
Right.
We need the detail and critical synthesis you need to move beyond just simple definitions and get into expert management.
Absolutely. We're going deep into the pathology, the modern diagnostic techniques, and critically, the differential management required when, minutes really matter.
If you look at the data historically, the three main categories, Placenta Previa, Abruptio Placentae, and then that indeterminate group, they have roughly equal incidence in hospital figures.
That's true, but their origins are completely different, aren't they? Placenta Previa is, primarily a mechanical problem. It's about displacement.
Right.
Whereas Abruptio Placentae is more of a chaotic physiological failure of the uteroplacental unit itself, often triggered by some kind of systemic disease.
So precision in telling these two apart.
It's absolutely non-negotiable.
Okay, let's begin our deep dive then with Placenta Previa, or PP. The name itself, Previa, meaning lying in front of, kind of tells the story, doesn't it?
It does.
At its simplest, how do we define this condition?
So Placenta Previa is the condition where the placenta is implanted, either partially or completely, over the lower uterine segment. Specifically, it's adjacent to or actually covering the internal os, the opening of the cervix. This abnormal positioning basically ensures that as the lower segment changes during pregnancy or labor, trauma and bleeding are pretty much inevitable.
Right. We know it accounts for roughly 1/3 of APH cases, with an incidence around, 0.5 to 1% of deliveries?
Yeah.
In that ballpark. But the risk factors, they're what truly dictate the modern prognosis, I think, and they paint a clear picture of why this might be becoming more common.
Absolutely. The risk factors, often listed in tables like box 19.1 in textbooks, are highly eliminating. You see demographic risks, like multiparity having had multiple previous births. That accounts for about 80% of cases.
80%, wow.
Yeah. And maternal age over 35, that carries roughly a 4-fold increase in risk.
Fourfold.
We also see links to multiple pregnancies, like twins, and infertility treatment. But the factor that really demands the most intense planning today
Is the scar tissue.
Exactly.
Yeah.
The presence of a uterine scar, whether that's from a previous cesarean section, a myomectomy to remove fibroids, or even prior curettage, like a D&C.
That correlation between prior uterine trauma, the scarring, and this placental displacement seems to be the key insight here.
It really is.
So why does the fertilized ovum decide to implant in this, perilous lower segment location? And how does a scar maybe act as an attractant?
Well, the precise etiology, the exact cause, is still somewhat theoretical. There are a few ideas.
Like the dropping down theory.
Right, that suggests the fertilized ovum just implants low down, maybe because the decidual reaction, the lining preparation in the upper segment wasn't good enough, or perhaps the zona pellucida, the egg's coating, didn't disappear at the right time. That could explain central PP.
Okay.
There's also the idea of persistence of chorionic activity, where placental tissue develops where it shouldn't, on the capsularis, and then contacts the lower segment. But if we want to focus on the clinically most relevant theory today...
It's the defective decidua idea.
I think so, yes. This theory posits that the decidua, the lining of the uterus, is somehow defective or poorly formed. And this is particularly relevant near a previous scar site.
Right, scar tissue isn't normal uterine lining.
Exactly. And if the decidua is defective, the trophoblast, which is the early placental tissue, responds how?
It needs to find nourishment, right?
Precisely. The trophoblast is programmed to find nourishment to get a good blood supply. If the lining is poor, it has to spread out over a much wider area to seek sufficient blood supply.
Ah, okay.
The resulting placenta is often described as large and thin, almost membranous. It spreads so wide that it inevitably encroaches onto that lower segment.
And the scar tissue itself.
Because the scar tissue often lacks the robust decidual barrier that you find in the fundus, the top of the uterus, it essentially becomes a pathway of least resistance for this spreading trophoblast.
So this spreading behavior, this searching for nutrition, is the direct precursor to that whole spectrum of morbidly adherent placenta.
That's the connection. Precisely. We're talking about placental invasion. The search for nourishment leads the villi, the placental fingers, to aggressively grow into the underlying uterine wall.
And that gives us the different types of adherence.
Yes, placenta accreta is where it just adheres to the myometrium, the muscle layer. Placenta increta means the villi invade deep into the myometrium, and placenta procreta is the most severe. The villi perforate the entire uterine wall, the serosa, and can potentially invade adjacent organs like the bladder.
That's incredibly dangerous.
Extremely.
And if we look at the gross pathological anatomy of the placenta itself in PP, it's often described as, you said, large and thin, but also showing signs of wear and tear.
Yeah, you often see degeneration and infarction areas of tissue death and calcification. This is likely due to its suboptimal location and maybe compromised blood flow over time.
And there are often anomalies of the umbilical cord itself.
Yes, frequently. The cord might be attached right at the margin, the edge of the placenta, that's called a battledore insertion. Or, far more dangerous for the baby, it might be attached only to the membranes, the sac surrounding the baby. That's a velamentous insertion.
And that velamentous insertion is the direct link to the extremely high-risk condition, vasa previa.
Absolutely essential connection to make. Vasa previa occurs when, because of that velamentous insertion, the fetal blood vessels end up running unsupported across the membranes right over the internal os.
So they're exposed.
Completely exposed. If the membranes rupture, either spontaneously or if someone does an artificial rupture, those fragile fetal vessels can rupture as well.
And that's fetal blood being lost.
Purely fetal blood loss. The resulting hemorrhage is rapid, it's catastrophic, and it often leads to fetal exsanguination. The baby bleeding out, and mortality rates can be up to 50%. It demands immediate recognition.
Wow. Okay, let's revisit the classification of placenta previa itself. Historically, we use those 4 types shown in diagrams, like figure 19.1 often shows.
Right, the traditional types.
Type I, low-lined, type 2, marginal, type 3, partial central, and type 4, complete central.
That historical grading is useful context, definitely. But for modern practice and actual management planning, that detailed breakdown into 4 types is less important than the distance rule.
The 2-centimeter rule.
Exactly. Modern practice, adopted by organizations like the American College of Obstetricians and Gynecologists, or ACOG, focuses on really just 2 main categories. True placenta previa, where the placenta actually covers the internal os, versus low-lying placenta previa.
But low-lying means?
Low-lying means the placental edge is within 2 centimeters of the ocus, but doesn't actually cover it. That 2-centimeter margin is the crucial benchmark now for determining the mode of delivery.
Okay, that simplifies it clinically. But within those traditional types, Ofer, the source material specifically highlights the type 2 posterior previa as being particularly dangerous. Why that specific location?
Ah, the type 2 posterior. Yes, it's dangerous primarily because of geometry and physiology.
How so?
Well, the thickness of the placenta when it's located posteriorly overlies the rigid sacral promontory, that bony part of the mother's pelvis. This creates a mechanical block. It prevents the fetal head from descending and engaging properly in the pelvis.
Which means?
The presenting part, the head usually, cannot act as an effective tamponade to compress the bleeding site if bleeding starts.
Okay.
Furthermore, if a provider were to attempt a vaginal delivery in this situation, the compression of the placenta against that bony sacrum dramatically increases the risk of cord compression or prolapse, leading to fetal anoxia and also severe trauma to the placenta itself. It's just a bad situation mechanically.
Makes sense. Now, regarding the bleeding itself, the hallmark of PP, we established it's sort of inevitable, physiological and mechanical.
That's right. As the pregnancy progresses, especially into the 3rd trimester, the lower uterine segment is designed to stretch, thin out, and eventually dilate for birth.
But the placenta can't stretch.
Exactly. The placenta is relatively inelastic. So as the segment beneath it stretches and thins, the placenta is physically sheared off the uterine wall. This tearing action opens up the underlying uteroplacental blood vessels.
And that's the source of the bleeding.
Yes. The bleeding is usually maternal blood, typically bright red. And the separation can be provoked by anything that disturbs the cervix or lower segment intercourse, an external version attempt, or, most dangerously, that internal vaginal exam we keep mentioning.
The body does try to stop it, right? Through thrombosis and maybe mechanical pressure from the baby.
It does try. Thrombosis, clot formation in the vessels happens. If the presenting part is low enough, it can apply some pressure, and sometimes areas of the placenta infarct, which stops bleeding from that specific spot. But there's a phenomenon that offers some hope, especially for an early diagnosis: placental migration.
Right. This is a massive clinical nuance, isn't it?
Huge. When a low-lying placenta is detected early, say, at the routine 20-week anatomy scan, where the incidence might seem high, maybe 10%, the prognosis for resolution is actually excellent.
How high?
Often over 90% resolved by term. It's not true migration, though.
Okay, so what's happening?
It's due to two factors working together. First, the sheer physical expansion of the lower uterine segment.
It just grows bigger.
A lot bigger. It expands exponentially, maybe up to a 10-fold increase in surface area between 20 weeks and term. As the lower segment stretches upwards and outwards, the relative position of the placental margin just gets pulled away from the os.
Okay, that makes sense. And the second factor?
The second is a biological drive known as trophotropism.
Trophotropism.
Yeah, it's essentially the preferential growth of the trophoblastic tissue, the active placental tissue, towards the areas with the best blood supply.
Which is usually higher up.
Right, towards the nutrient-rich fundus, which has the thickest, best perfused decidua. It's like the placenta is chasing the best food source.
So it's not physically sliding up the wall.
No, not at all. But the bulk of the actively growing tissue is migrating away from the relatively nutrient-poor lower segment. This directional growth effectively draws the lower edge of the placenta away from the internal os over time.
So that's why an initial diagnosis of low-lying placenta warrants patience and repeat scanning, not immediate panic.
Precisely. You watch and wait, usually with follow-up scans.
Okay, let's shift to the clinical presentation. This is where the differentiation from Abruptio Placentae really begins, isn't it?
Absolutely. They present very differently.
The classic description of Placenta Previa bleeding uses 4 adjectives that everyone needs to memorize.
The classic quad, yes.
Yeah.
It's sudden onset, painless, apparently causeless, and recurrent.
Sudden, painless, causeless, recurrent. That's the mnemonic for Previa.
Exactly. You picture a patient, maybe she wakes up suddenly, perhaps in the middle of the night, and finds she's bleeding vaginally.
Okay.
There was no obvious trauma, no exertion beforehand, and crucially, there is no pain associated with the bleeding itself, unless, of course, she happens to be in labor simultaneously, but the bleeding itself isn't the source of pain.
And the first episode, often slight.
Often quite slight,
Yeah.
yes. It's sometimes called the warning hemorrhage,
Okay.
but it absolutely demands immediate attention and investigation.
And that warning is critical because, unfortunately, subsequent bleeds tend to get heavier.
They often do, yes. That's thought to be due to fresh, maybe larger areas of placental separation occurring with each subsequent episode.
Okay. And when we do a gentle abdominal examination, the signs are also distinct from abruption.
Very distinct. The uterus feels soft, completely relaxed and elastic. There's no localized tenderness or rigidity, none of that woody, hard feeling you might get with abruption.
And the baby's position.
The fetal lie is often abnormal. You frequently find malpresentation like a breech baby, or a transverse lie where the baby's sideways, or even an unstable lie where the position keeps changing.
Why is that?
Because the placenta is physically occupying the space in the lower segment where the fetal head would normally settle and engage in the pelvis. Consequently, the fetal head is typically high and floating, not fixed in the pelvis.
We also noted Stallworthy's sign described in some texts where pressing the fetal head down causes a transient slowing of the fetal heart rate. Is that reliable?
It suggests the head might be compressing a low-lying placenta or perhaps the umbilical cord posteriorly, but it's not absolutely definitive or routinely used anymore, especially with good imaging available.
Right. What is definitive, though, and what needs to be hammered home again and again?
Is the absolute prohibition on unmonitored vaginal examination.
Vaginal examination must be avoided outside a controlled setting.
Absolutely. It must be avoided unless you are in a dedicated operating theater, fully prepared for an immediate cesarean section and massive blood transfusion. This is sometimes called a double setup procedure. And even then, you typically only consider it if imaging has been inconclusive, which is rare nowadays.
Why is it so dangerous?
Because the act of palpating the cervix trying to feel for the placenta, can immediately provoke catastrophic torrential hemorrhage. You're physically disturbing the already separated placental margin or causing further separation.
So what examination is permissible?
Really, only a gentle external inspection of the perineum to note the character of the blood. Is it bright red, suggesting fresh maternal blood? And to estimate the amount. That's it. No internal fingers.
So diagnosis overwhelmingly relies on imaging, or placentography as it's sometimes called, specifically ultrasonography.
Yes, ultrasound is the diagnostic technique of choice. The Royal College of Obstetricians and Gynecologists, RCOG, and other bodies confirm this.
Let's compare the methods. Transabdominal ultrasound, TAS.
TAS, scanning through the abdomen, is a good initial screening tool. It offers pretty high accuracy, especially after 30 weeks. But it definitely has limitations.
Such as?
A full bladder, which used to be required, can actually compress the lower segment and artificially make the placenta look closer to the os than it is a false positive. Strong uterine contractions can do the same thing. Also, maternal obesity can make visualization difficult, and critically, if the placenta is posterior, the fetal head can cast an acoustic shadow, completely obscuring the view of the internal os.
Which is exactly what you need to see clearly.
Precisely. This is why transvaginal ultrasound, TVS, is considered dramatically superior.
Gold standard.
Pretty much, yes. TVS offers virtually 100% accuracy for diagnosing placenta previa. The probe is positioned in the vagina, much closer to the target area, the internal os and lower segment.
But it doesn't touch the cervix.
Correct. The technique ensures the probe doesn't actually touch the cervix, so it's safe. It provides superior image resolution, bypasses the need for an uncomfortably full bladder, and gives the most precise objective measurement of that crucial distance between the placental edge and the internal os.
And for those really tricky cases, maybe where adherence is suspected or for that difficult posterior previa, we need more advanced imaging.
Yes, absolutely. Color Doppler and increasingly three-dimensional power Doppler become essential tools.
How do they help?
Color Doppler helps by showing blood flow patterns, maybe highlighting diffuse vascular lakes in the placental bed. But 3D power Doppler is often noted as superior because it's highly effective at visualizing hypervascularity, excessive blood vessel formation, right at that critical junction between the uterine serosa, the outer layer, and the bladder wall. That's a strong indicator of placental invasion, like accreta or procreta.
And if even that isn't clear enough?
For the deepest, most complex cases, especially a posterior previa where ultrasound visibility might still be limited, or if you strongly suspect deep invasion procreta, possibly involving the bladder, then magnetic resonance imaging, MRI, is the non-invasive imaging modality of choice. It gives fantastic anatomical detail.
So the primary advantage of all this meticulous imaging isn't just getting the diagnosis right.
No, it's about preemptive risk stratification, especially for the accreta spectrum.
This is the modern clinical reality, isn't it? That risk calculation we mentioned earlier must drive every single decision.
It absolutely has to. If a woman presents with placenta previa and she has just one prior cesarean section, her risk of having an accreta is already somewhere between 10 to 15%.
That's significant.
It is. Now, if she has had 3 or more prior cesarean sections, that risk skyrockets to an astonishing 60%. 60% chance of morbidly adherent placenta.
So you're no longer just preparing for a potentially complicated delivery.
No, you are preparing for potentially massive hemorrhage, likely damage to adjacent organs like the bladder, and a very high probability of needing a cesarean hysterectomy. The whole mindset has to shift.
Let's quickly summarize the potential complications of PP, which can be devastating. On the maternal side, it's really a cascade of hemorrhage risk.
Yes, hemorrhage before delivery, antepartum, during delivery, intrapartum, and critically, after delivery, postpartum. This leads to shock, anemia, and almost guarantees increased operative intervention, primarily cesarean section.
And postpartum hemorrhage has specific reasons for being worse in PP.
It does. First, the lower uterine segment, where the placenta is attached, is anatomically less muscular than the upper segment. Therefore, it retracts imperfectly after the baby is born, failing to clamp down effectively on the blood vessels.
Okay.
Second, the sheer size of the placenta itself, often being large and thin as we discussed, more surface area bleeding. And third, the presence of that morbid adherence, the accreta spectrum, which complicates up to maybe 15% of BP cases overall, and is often the direct reason for uncontrollable bleeding necessitating emergency hysterectomy.
Historically, maternal death causes were hemorrhage, maybe operative hazards, sepsis, or embolism.
Thankfully, in modern, well-resourced centers, maternal mortality from PP itself is approaching 0. but it remains a significant cause of maternal death in developing countries.
And for the fetus, the outlook is equally concerning, if not more so sometimes.
Yes, the biggest single risk is prematurity. This is often iatrogenic, meaning we have to deliver the baby early because of maternal bleeding, or it can be due to spontaneous preterm labor triggered by the bleeding or inflammation. Prematurity is the most common cause of low birth weight in these babies.
What else?
We also see higher rates of fetal growth restriction, or FGR. This might be due to chronic placental insufficiency, resulting from the repeated small hemorrhages, or just the suboptimal implantation site.
And acute risks.
Acute asphyxia can happen during a large bleed due to placental separation or cord compression. Sadly, intrauterine death can occur. There's also a risk of birth injuries during delivery, and disturbingly, the data consistently shows about a threefold increased incidence of congenital malformations in babies from pregnancies complicated by Placenta Previa. The reasons for that association aren't entirely clear.
So modern obstetrics has really dramatically changed the prognosis for Placenta Previa, hasn't it?
Oh, absolutely. Compared to even a few decades ago, it's night and day in many places.
Early ultrasound detection, that rigorous avoidance of unnecessary internal exams, readily available blood transfusion, liberal use of cesarean section, and advanced surgical preparation
Have collectively made maternal mortality from PP virtually extinct in resource-rich settings. Although, as we said, it remains a major killer in low-resource settings.
So management begins immediately upon suspicion or diagnosis if a patient has a bleed at home.
The protocol is clear: immediate bed rest, gentle assessment only. And critically, the immediate establishment of an intravenous line start with a crystalloid solution like Ringer's lactate in preparation for transfer to a highly specialized hospital.
And that transfer destination is key.
It has to be to a facility capable of providing 24-hour emergency cesarean section capability, immediate access to blood and blood products, and a neonatal intensive care unit, an ICU for the baby who is often preterm.
Upon arrival at the hospital, the immediate focus is restorative and diagnostic.
Right. Quick assessment of the amount of blood loss. Secure large bore 5E access, often 2 lines if possible. Draw blood immediately for grouping, cross-matching, hemoglobin estimation, and maybe coagulation studies if the bleeding is heavy. And then begin continuous maternal vital sign monitoring and fetal heart rate monitoring.
Once the patient is stabilized, the core decision is expectant versus active management.
Exactly. Expectant management, famously advocated by McAfee and Johnson way back in 1945, is essentially the attempt to buy time, to gain precious weeks or months for fetal maturity.
What's the main aim?
The aim is simple: continue the pregnancy until the baby is mature enough to survive outside the womb without significantly endangering the mother's health.
But this requires very strict prerequisites, doesn't it?
Absolutely stringent. The mother must be hemodynamically stable. That generally means a hemoglobin level above 10 grams per deciliter, hematocrit above 30%. The pregnancy must be preterm, usually defined as less than 37 weeks. Crucially, there must be no active, continuous bleeding. Fetal well-being must be constantly assured through monitoring. And, perhaps most importantly, that immediate 247 capability for cesarean section and blood transfusion must be available in-house. You can't wait for resources to arrive.
And the conduct of expectant management.
It involves strict bed rest, although the degree of strictness is sometimes debated now. Serial fetal surveillance using ultrasound every, say, 2 to 3 weeks to monitor fetal growth and reassess the placental position relative to the os. And aggressive replacement of any blood loss to keep the mother's hematologic status optimized.
What about examining the patient?
A gentle speculum examination is usually performed only once, and only after the acute bleeding episode has completely stopped. The sole purpose is to exclude other local causes of bleeding, like cervical polyps or lesions, which can occasionally mimic PP, no digital exams.
And if the patient starts having contractions during expectant management?
Pharmacologic intervention might be needed. Tachylysis, using drugs to stop contractions, often magnesium sulfate, can be employed cautiously to try and settle the uterus and prolong the pregnancy.
But only if.
Only if there's no evidence of significant ongoing placental separation or fetal compromise. You don't want to stop contractions if delivery is actually necessary.
And steroids.
We must administer corticosteroids, specifically betamethasone usually, if delivery seems likely before 34 weeks of gestation, to help accelerate fetal lung maturity. That's standard practice.
Is there any role for cervical cerclage, stitching the cervix closed?
No. RCO guidelines from 2005 confirmed that cervical cerclage is not helpful in Placenta Previa. It doesn't reduce bleeding or prolong gestation and might even cause harm.
Okay. So that's expectant management. Active management means delivery. When is that mandated?
Active management, meaning proceeding to delivery, is indicated when those prerequisites for expectant management fail, or when the baby reaches sufficient maturity, typically considered 37 weeks.
So specific indications would be
Reaching 37 weeks gestation, the onset of active labor, regardless of gestation. If the mother presents in an exsanguinated state or has continuing moderate to severe bleeding despite conservative measures, or, of course, any sign of non-reassuring fetal status on monitoring.
And the mode of delivery, it hinges entirely on that precise sonographic mapping, that 2-centimeter rule.
Almost entirely, yes. If ultrasound confirms the placental edge is within 2 centimeters of the internal os, or if it's a posterior, particularly thick placenta close to the os, then cesarean delivery is mandated for maternal and fetal safety.
Vaginal delivery is only an option when?
Vaginal delivery is only considered in highly select cases, typically what used to be called type Y, or maybe a type 2 anterior previa, where the placental edge is clearly documented by reliable ultrasound, preferably TVS, as being 2 to 3 centimeters or more away from the internal os. And even then, it requires careful consideration and readiness to convert to CS.
In those rare selected cases where vaginal delivery is attempted, performing a low rupture of the membranes, or amniotomy, serves a specific purpose.
It does. Amniotomy, artificially breaking the waters, is done for two main reasons here. First, it can help accelerate the labor process. Second, and perhaps more importantly in this context, it allows the presenting fetal part, ideally the head, to descend and apply direct pressure, or tamponade, onto the bleeding placental site, potentially helping to arrest the hemorrhage.
But if that amniotomy doesn't work quickly?
If amniotomy fails to promptly stop significant bleeding or fails to accelerate labor effectively, you must abandon the attempted vaginal delivery and immediately transition to an emergency cesarean section. There's no room for prolonged waiting.
This brings us squarely to the surgical dilemma. Performing a cesarean delivery in the presence of placenta previa. This is where that multidisciplinary team becomes absolutely critical.
It's paramount. The preparation must involve not just a senior, experienced obstetrician, but also a specialized obstetric anesthetist who understands the risks, dedicated transfusion specialists or blood bank support, and sometimes even a urologist on standby, especially if accreta involving the bladder is suspected.
The crucial goal during the surgery itself is,
ideally, to incise the uterus away from the placenta, especially if you suspect adherence, accreta.
Let's compare the standard approach, the lower segment cesarean section LCS, the horizontal cut lowdown, against its risks in PP.
LCS is the standard uterine incision most obstetricians are comfortable with. Its advantage is it offers good visualization for controlling bleeding points after delivery and helps in deciding if a hysterectomy might be needed. But
the disadvantages in PP.
In an anterior previa where the placenta is on the front wall, the disadvantages are potentially terrifying. You risk cutting directly into the placenta or through the large engorged blood vessels in the lower segment where the placenta is attached, leading to profuse bleeding before you even reach the baby.
And if the placenta is cut?
If the placenta has to be cut to deliver the baby, which happens frequently in central anterior previas, you risk massive maternal hemorrhage, obviously, but also almost certain rapid fetal exsanguination as fetal blood pours out from the severed placental vessels.
The source emphasized a crucial step for the fetus if the placenta is cut accidentally.
Yes. That umbilical cord must be clamped immediately. The instant you realize you've cut into the placenta, clamp the cord. The baby's outcome hinges on stopping that fetal blood loss and resultant hypovolemia right away.
Any other issues with LCS and Previa?
Well, the tissues of the lower segment in PP are often more friable, more vascular, and prone to poor healing and retraction, making subsequent attempts at suturing to achieve hemostasis more difficult than in a routine CS.
What about the alternative, the classical cesarean section, that vertical incision higher up on the fundus? Is that ever used?
It's less common now, but sometimes considered. The potential advantages are that it's often quicker to get the baby out, and you can usually deliver the baby without disturbing the placenta at all, completely eliminating that risk of cutting into it and causing fetal exsanguination. It might also potentially allow the uterus to be preserved in some specific accreta cases where the adherence is confined low down.
But the downsides?
The classical incision carries higher general risks for the mother in terms of future pregnancies, uterine rupture risk, and critically, it prevents direct visualization of the lower segment placental bed after delivery, making it very difficult to identify and control bleeding points originating from down there.
Okay. Assuming we proceed with delivery, LCS or classical, how do we manage the often massive lower segment hemorrhage that occurs after the baby is out?
If simple measures fail, like ensuring the uterus is well contracted with oxytocics, maybe oversewing obvious bleeding points, then you have to escalate rapidly.
What techniques are used?
Techniques include applying compression sutures like the B-lint suture, which essentially wraps around and physically compresses the entire uterus. Sometimes specific sutures targeting the lower segment itself, like the isthmic cervical apposition suture, can be used.
What about packing?
Tight intralotrum packing, using specialized tamponade balloons like a Bakri balloon, or even just tightly packed gauze, is a highly effective temporizing measure to control hemorrhage by applying direct pressure. These packs are typically removed after 24 to 48 hours.
Finally, let's talk about the absolute crisis scenario, managing placenta previa accreta, that morbid adherence. We've reiterated the risk potentially over 60% with multiple prior cesareans.
When morbid adherence, especially increta or percreta, is strongly suspected or diagnosed antenatally via imaging, the entire surgical strategy shifts. The management becomes almost counterintuitive.
Which is?
Deliver the baby, usually via a fundal or classical incision to avoid the placenta, clamp and cut the cord, and then do not attempt to separate the placenta.
No attempt at all.
No attempt. Attempting manual separation when morbid adherence is present guarantees massive, often uncontrollable hemorrhage from the raw placental bed, and almost invariably necessitates an immediate, often difficult emergency hysterectomy.
So we deliver the baby, cut the cord, and then what? Leave the placenta inside?
It depends. If the placenta is confirmed to be morbidly adherent, and there is minimal to no bleeding coming from around it after the baby is out, a conservative approach might be considered. This involves leaving the placenta entirely in situ and simply closing the uterine incision over it. The hope is for spontaneous resorption or fibrosis over weeks or months, often managed with medications like methotrexate, although this carries risks of infection and later bleeding.
But if there is bleeding?
If significant bleeding is present, which is common, then the standard and often safest approach is a planned controlled cesarean hysterectomy. This is typically performed immediately after delivering the baby and closing the initial uterine incision without ever attempting to peel the placenta off the uterine wall beforehand. Taking the whole uterus out with the placenta still attached is often less bloody than trying to separate it first.
This really highlights the crucial role of adjuvant therapies like interventional radiology.
Absolutely. They can be lifesavers. Surgical ligation of the uterine arteries or even the internal iliac arteries can be performed to reduce blood flow, but increasingly we rely on preoperative or intraoperative interventional radiology for uterine artery embolization.
How does embolization help?
It involves placing agents into the uterine arteries to block blood flow. This helps control hemorrhage during the hysterectomy, significantly reducing blood loss. In conservative management where the placenta is left in situ, embolization might be used to control bleeding or potentially facilitate the eventual absorption of the retained placental tissue.
The complexity is immense.
It really underscores why only senior, highly experienced multidisciplinary teams in tertiary centers should be managing suspected or confirmed cases of placenta accreta spectrum disorders.
Okay, we've spent significant time on placenta previa, which is essentially a mechanical displacement issue. Now, let's completely flip the script.
Right.
Let's focus on Abruptio Placentae, the premature separation of a normally situated placenta. This is often the more chaotic, unpredictable, and systemically devastating cause of antepartum hemorrhage.
That's a good way to put it. Unlike PP, where the placenta separates because it's just in the wrong place relative to the stretching lower segment, Abruptio Placenta, or AP, separates because of a hemorrhage that begins deep within the decidual basalis, the lining right underneath the normally implanted placenta.
And this initial bleed.
This initial bleed forms a retroplacental hematoma, a blood clot behind the placenta, which then physically shears the placenta off the underlying uterine wall, disrupting the blood supply to the fetus.
We usually categorize AP into 3 types based on where the blood goes, right?
Yes. 1. Revealed abruption. This is the most common type. Here, the blood manages to track downward between the membranes and the uterine wall and becomes visible externally as vaginal bleeding.
Okay.
2. Concealed abruption. This is rarer, maybe 10 to 20% of cases, but it's extremely dangerous because the blood remains trapped behind the placenta or within the uterine cavity behind intact membranes. The true extent of the hemorrhage is completely hidden from external view.
Which can lead to underestimation of the severity.
Exactly. And 3, mixed abruption, which is actually quite common, where there are elements of both concealed hemorrhage and some revealed external bleeding.
When we investigate the etiology, what's actually driving this initial hemorrhage into the decidua vasalis? What is the single most important underlying factor we see?
Overwhelmingly, the evidence points to hypertension in pregnancy as the most significant factor. It's present in somewhere between 10 to 50% of severe abruption cases. This includes preeclampsia, gestational hypertension, or chronic essential hypertension.
And how does hypertension cause the separation?
The presumed pathogenesis involves chronic vasospasm in the small spiral arteries that supply the placenta. This vasospasm leads to chronic hypoxia, damage to the endothelial lining of these vessels, and eventually necrosis and rupture, causing bleeding into the decidua.
And beyond hypertension, what are the other key risk factors we should know?
Well, high parity, having had many previous births, is a classic risk factor. Advancing maternal age also plays a role. Lifestyle factors like cigarette smoking are strongly linked.
What about trauma?
Yes, mechanical factors are important. Blunt abdominal trauma, like from a car accident or a fall, can cause abruption. Forceful external cephalic version attempts to turn a breech baby can also trigger it.
And sudden uterine decompression?
That's another critical mechanism. For example, the sudden gush of amniotic fluid after artificially rupturing the membranes in a woman with polyhydramnios, excessive fluid, or sometimes immediately following the delivery of the first twin in a multiple pregnancy. The rapid change in uterine volume and pressure can shear the placenta.
Any others?
We're also increasingly recognizing the role of underlying thrombophilia's maternal clotting disorders. And substance abuse, particularly cocaine use, is a major risk factor because cocaine is a powerful vasoconstrictor and can acutely raise blood pressure, leading to vessel rupture. Prior abruption is also a very strong risk factor for recurrence.
Pathologically, the most dramatic finding, especially in severe concealed abruption, is the Couvelaire uterus. That sounds quite alarming.
It looks alarming too. Couvelaire uterus, also called uteroplacental apoplexy, is the result of massive intravasation of blood. The sheer pressure from that contained retroplacental hematoma forces blood not just sideways, but deep into the muscle wall of the uterus, the myometrium, sometimes extending right up to the outer serous coat.
What does it look like?
On abdominal entry during a cesarean, the uterus is visibly bruised, dark, often described as a deep port wine color or purplish, due to this widespread intramyometrial hematoma. It looks boggy and unhealthy.
Now, the critical clinical insight here is about management. Does seeing that alarming appearance automatically mean a hysterectomy is needed?
That's a really important point. Historically, maybe yes, but clinically, the answer now is generally no. While dramatic, the myometrial hematoma itself rarely interferes significantly with the uterus's ability to contract effectively after the baby and placenta are delivered.
So the uterus can still clamp down?
Usually, yes. Therefore, the presence of Couvelaire uterus itself is not an automatic indication for hysterectomy. You only proceed to hysterectomy if you cannot achieve adequate hemostasis through standard uterotonic medications and surgical techniques after delivery. Don't take the uterus out just because it looks bruised.
Okay. Beyond the uterus itself, AP can cause profound systemic changes in the mother. Specifically, the acute renal and hematological insults are often devastating.
They are. The kidney damage is acute, ranging from milder acute tubular necrosis, ATN, to severe irreversible acute cortical necrosis. This is driven primarily by the profound hypovolemia from the hemorrhage, combined with the severe vasospasm often associated with the underlying hypertensive state, or the shock itself. Reduced blood flow kills kidney tissue.
But the most immediate, life-threatening systemic complication is often the blood coagulopathy, disseminated intravascular coagulation, or DIC.
Absolutely. DIC is a major killer in severe abruption.
Let's detail the mechanism of DIC here. Why does Abruptio Placentae specifically cause such widespread consumption of clotting factors?
It's because when the placenta separates and the underlying decidua is damaged, massive amounts of tissue factor, also known as tissue thromboplastin, are released directly into the maternal circulation.
And thromboplastin triggers clotting.
Yes, it's a powerful activator of the extrinsic clotting cascade. This flood of thromboplastin triggers widespread systemic activation of clotting, causing microthrombi, tiny clots, to form throughout the body's small blood vessels.
Consuming the clotting factors in the process.
Exactly. The body rapidly consumes its own clotting factors, particularly fibrinogen and platelets, as well as other factors, at a completely unsustainable rate. This leads to hypofibrinogenemia, where fibrinogen levels plummet, often falling critically low, sometimes below 100 or 150 milligrams per deciliter.
What else do we see in the blood tests?
Alongside the low fibrinogen and platelets, you see rapidly elevated levels of fibrin degradation products, FDPs, and D-dimer, which are breakdown products of clots. Essentially, the patient is paradoxically bleeding because she's used up all the components she needs to form stable clots, while simultaneously forming inappropriate microclots systemically.
It's a vicious cycle.
A truly dangerous one.
The clinical grading of abruption is essential because it immediately dictates the severity of the situation and the response needed.
Yes, the traditional grading system, typically grades 1, 2, and 3, is very useful clinically. Grade 1 represents about 40% of cases. It involves slight external bleeding, maybe an irritable or tender uterus, but crucially, the maternal vital signs are stable, fibrinogen levels are unaffected, and the fetal heart sounds are usually good. This is the least severe form, but still requires very close monitoring.
Okay, then grade 2, that's the moderate abruption.
Right. Grade 2 accounts for about 45% of cases. It's defined by mild to moderate visible or concealed bleeding. Critically, uterine tenderness is always present in grade 2. The maternal pulse rate will typically be increased, although blood pressure might initially be maintained. Fibrinogen levels start to fall. And, most importantly for prognosis, the fetus will almost always demonstrate signs of distress on monitoring, or in many grade 2 cases, fetal death has already occurred before presentation. Shock is usually absent or mild.
In grade 3, this is the catastrophic event.
Grade 3, about 15% of cases, involves moderate to severe bleeding, which is often largely concealed. It's characterized by marked uterine tenderness and a palpable board-like rigidity, that classic description of a woody hard uterus due to the tense hematoma.
And systemic effects.
Maternal shock is pronounced and often seems way out of proportion to any visible blood loss. Fetal death is unfortunately the rule in grade 3 abruption, and this grade is almost universally associated with significant coagulation defects, DIC, and subsequent acute renal failure, presenting as oliguria, low urine output, or nonuria, no urine output.
Okay, let's pull the trigger now on the definitive differential diagnosis in the emergency setting. Placenta Previa versus Abruptio Placentae. Getting this right fast is paramount.
Absolutely. You can use a comparison table mentally, like the one often shown as Table 19.1. Think about the nature of the bleeding. PP is typically painless, seemingly causeless, often recurrent, and the blood is usually bright red, maternal arterial. AP is typically painful, often associated with an obvious cause, like hypertension or trauma. The bleeding tends to be continuous rather than recurrent episodes, and the blood is often dark-colored, older blood from the hematoma.
What about the presence of shock and anemia?
This is a key differentiator. In PP, the degree of shock or anemia is usually proportionate to the visible external blood loss. You see a lot of blood, the patient looks shocked. In AP, particularly concealed abruption, the shock is often severely out of proportion to the visible external blood loss. The patient might look pale, clammy, hypotensive, tachycardic, with very little showing externally. That discrepancy screams concealed abruption and systemic effects like DIC.
And the final big clinical sign, the feel of the uterus itself.
Completely different. The uterus in PP feels soft, relaxed, non-tender, and elastic between contractions if they are present. The uterus in AP is characteristically tense, tender to palpation, and often rigid or woody hard due to the contained hematoma and myometrial irritation.
And placentography.
Ultrasound will show the placenta in the lower segment in PP. In AP, the placenta is normally sighted, usually in the upper segment or fundus, though ultrasound might sometimes show the retroplacental clot itself.
The prognosis for the fetus in AP seems inherently worse than in PP, even for similar amounts of bleeding. Why is that?
Yes, the perinatal mortality rate is significantly higher in AP, maybe 10 times higher than the baseline rate.
Yeah.
The fundamental reason is that AP often involves a placenta that already had poor functional reserve before the separation occurred. This is usually due to the underlying vascular pathology, like chronic hypertension, which caused the abruption in the first place.
So the remaining placenta can't compensate?
Exactly. When a portion separates, the remaining placental area often cannot compensate adequately to maintain fetal oxygenation, leading to rapid fetal distress or demise. In contrast, in PP, the placenta itself might be perfectly healthy and functioning normally, it's just a wrong location. So if the bleeding can be controlled, the fetus might tolerate it better, assuming prematurity isn't an issue.
Okay, given the high stakes and often rapid deterioration associated with Abruptio Placentae, prevention is obviously key, focusing primarily on controlling those known risk factors we discussed.
It is. The focus is really multifaceted. It includes scrupulous management and control of hypertensive disorders throughout pregnancy. It means performing invasive procedures like amniocentesis only when necessary and always under rigorous ultrasound guidance to avoid placental injury. What else? General advice on avoidance of abdominal trauma, avoiding forceful external version attempts if possible, and critically, avoiding sudden, rapid uterine decompression. If you need to manage severe polyhydramnios, a controlled amniocentesis to remove fluid slowly is generally preferred over just artificially rupturing the membranes, which can precipitate an abruption due to the rapid volume change.
But once AP is diagnosed, the treatment philosophy is pretty straightforward, isn't it?
Generally, yes. Immediate delivery is the cornerstone of management in most instances.
Is there ever a role for expectant management?
It's a highly restricted exception. It might only be considered in very carefully selected cases of grade I abruption, usually diagnosed incidentally or with minimal symptoms, where the pregnancy is very remote from term, the bleeding is completely ceased, and both the maternal and fetal condition are demonstrably stable with intensive monitoring. But for almost all grade 2 and grade 3 abruptions, or any significant ongoing bleeding, immediate delivery is absolutely required. Time is not on your side.
Okay. If the patient presents already in active labor with an abruption, what's the goal?
The goal is usually to accelerate the delivery process, ideally via vaginal birth, if possible and safe. The key intervention here is often a low rupture of the membranes, or amniotomy.
And amniotomy offers multiple advantages in this specific situation.
Yes, several significant ones. First, it usually helps to accelerate the labor and expedite delivery. Second, and perhaps critically in abruption, breaking the waters allows the uterus to contract down more effectively around the fetus, increasing the resting tone. This mechanically compresses the bleeding spiral arteries at the placental site, potentially helping to arrest the hemorrhage.
Any other benefits?
Yes. Thirdly, by decompressing the uterine cavity and the placental bed somewhat, it theoretically reduces the pressure gradient driving tissue thromboplastin into the maternal circulation, thereby potentially reducing the risk or severity of DIC and associated acute renal failure. So, vaginal delivery, augmented by amniotomy and possibly oxytocin, is often favored if the abruption seems limited and the fetal heart rate tracing is reassuring.
But if the patient is not in labor, or if the abruption is clearly severe, grade 3, cesarean section becomes the more likely choice.
Often, yes. The decision between induction of labor, amniotomy plus oxytocin, versus immediate cesarean section depends on several factors.
What are the definitive indications for choosing CS in AP?
Generally, indications for primary cesarean delivery would include severe abruption, definitely grade 3, often grade 3, particularly if the fetus is still alive but showing distress. Also, if the cervix is unfavorable for induction, long closed posterior. If an initial attempt at amniotomy fails to control the bleeding or fails to arrest the progression of the abruption, for example, the uterus continues to get bigger and harder, or, of course, the appearance of other adverse features like overt fetal distress requiring immediate rescue, a rapidly falling fibrinogen level suggesting worsening DIC, or oliguria indicating renal compromise.
Any considerations regarding anesthesia for the CS?
Yes, that's important. Regional anesthesia, like an epidural or spinal, is often relatively contraindicated or must be used with extreme caution in severe abruption. This is because these patients are often already hypovolemic, potentially coagulopathic, and prone to severe vasospasm. A spinal or epidural can cause profound hypotension in this setting. General anesthesia is frequently preferred for the cesarean in severe abruption to better manage hemodynamic stability.
Managing the hemorrhagic shock and the DIC simultaneously seems like the biggest immediate challenge in severe AP. Let's focus on the shock management first.
Early, aggressive resuscitation and correction of hypovolemia are absolutely paramount, and you have to remember that key nuance we discussed. Blood pressure is not a reliable guide to the true volume status in these patients.
Why not?
Because the patient may have severe pre-existing vasospasm from underlying hypertension or vasospasm induced by the shock state itself, which can artificially elevate the blood pressure reading despite profound intravascular volume depletion.
So what's a more reliable measure?
Invasive monitoring, like central venous pressure, CVP, can be very helpful, although it's used less routinely now. The main goals are clinical, restoring adequate tissue perfusion. This often means transfusing blood and fluids aggressively based on clinical signs, pulse, capillary refill, mental status, and aiming to maintain adequate urine output at least 30 milliliters per hour as a key indicator of renal perfusion.
How much blood?
You have to anticipate large losses, especially with concealed abruption. It's often recommended to transfuse a minimum of 1 liter, maybe 2 units, of packed red blood cells immediately, even if the initial assessment seems like only moderate loss, and then titrate further based on the clinical picture and lab results, aiming to keep the hematocrit ideally above 30%. Large bore 5e access is essential.
And then managing the coagulopathy, the DIC.
The treatment for DIC is really twofold and needs to happen concurrently with resuscitation. First, you must aggressively replace the consumed clotting factors to restore hematologic deficiency.
How is that done?
This means giving blood products rich in clotting factors. Fresh frozen plasma, FFP, provides most factors, and cryoprecipitate is particularly rich in fibrinogen. Platelet transfusions are given if the platelet count is critically low. The critical laboratory goal is usually to keep the fibrinogen level above a certain threshold, often cited as 150 or even 200 milligrams per deciliter, to ensure effective clot formation. Massive transfusion protocols are often activated.
And the second part of DIC treatment?
The second, and ultimately definitive part, is to arrest the entire pathological process by achieving delivery and removing the source of the thromboplastin.
Get the placenta out.
Exactly. Once the placenta is delivered, the stimulus for the ongoing intravascular coagulation is removed, and the maternal coagulation system can usually begin to recover and stabilize, often quite rapidly, provided the shock and hypoperfusion have been adequately treated.
We also need to consider the fetus in all this, especially regarding potential preterm delivery.
Absolutely. If the situation allows, meaning if delivery is anticipated to be preterm, but isn't immediately emergent for maternal reasons, then giving betamethasone for fetal lung maturity is important.
What about tachylysis? Any role for drugs to stop contractions and abruption?
This is controversial. Tachylysis is generally contraindicated in significant abruption because you don't want to delay necessary delivery. However, some evidence suggests that magnesium sulfate, text MgSO14-1, might be used cautiously in very specific mild preterm cases, not just for tachylysis, but also because it might potentially reduce further placental separation through smooth muscle relaxation. And importantly, text MgSO4 also acts as a neuroprotector for the preterm infant, reducing the risk of cerebral palsy. But it requires extremely careful selection and monitoring.
And RhoGAM.
Yes, absolutely crucial. Anti-D immunoglobulin, like RhoGAM, must be administered to all Rh-negative women experiencing an abruption, regardless of the gestation. Fetal-maternal hemorrhage is very common in abruption, particularly it's caused by trauma, and anti-D prevents Rh sensitization.
Okay, finally, we must briefly touch on that third category, the indeterminate bleeding group. This sounds like a diagnosis of exclusion.
It absolutely is. It's made only after you've meticulously ruled out both Placenta Previa, usually with ultrasound, and Abruptio Placentae, based on clinical signs and maybe ultrasound, and you've excluded local causes of bleeding from the lower genital tract, like cervical ectropion, polyps, or even cancer, usually via a careful speculum examination.
So if it's not PP, not AP, and not a local lesion, what could it be?
Well, potential causes include things like a marginal sinus hemorrhage, where the bleeding originates just from the very edge of the normally implanted placenta. Sometimes a circumvallate placenta, which is an anatomical variant, can be associated with bleeding. It could simply be an excessively heavy, bloody show as labor starts. But the most clinically urgent possibility hiding in this indeterminate group is the rupture of vasa previa.
Right, we mentioned vasa previa earlier under PP complications with velamentous insertion. It's an obstetric nightmare because of the extreme fetal risk.
It truly is. To recap, it's those unsupported fetal umbilical blood vessels running across the cervical os, usually associated with a velamentous cord insertion or maybe a successory placental lobe.
And the danger.
The danger is massive fetal mortality, potentially 50% or higher, because if those vessels rupture, typically when the membranes break, the blood loss is purely fetal blood, and its sanguination can occur literally within minutes.
How is it diagnosed if suspected?
The diagnostic key nowadays is antenatal ultrasound, specifically using color flow Doppler during a transvaginal scan, PVS. This can often visualize those vessels crossing the os. If bleeding occurs acutely and you suspect vasa previa rupture, confirmation that the blood is fetal can be done using specific chemical tests on the vaginal blood, like the AP test or the Singer's alkali denaturation test, which differentiate fetal hemoglobin, HbF, from adult hemoglobin, HbA. But often there isn't time for testing.
So management of confirmed or highly suspected vasa previa has to be aggressive.
Extremely aggressive and proactive. If diagnosed antenatally, these patients require planned hospitalization, often starting somewhere between 28 and 32 weeks gestation, to ensure they are in a place capable of immediate surgical intervention if needed.
And steroids.
Yes, a course of steroids must be administered for fetal lung maturity. And delivery is almost always performed by a planned elective cesarean section prior to the onset of labor or membrane rupture, often around 34 or 36 weeks.
And if bleeding does occur before the planned CS?
If any bleeding occurs, even spotting, in a woman with known vasa previa, it is automatically deemed a Category 1 emergency cesarean section, meaning immediate delivery is required, usually within 30 minutes, to save the baby. There's no scope for expectant management once bleeding starts. #HouchAftro.
So after that incredibly detailed dive, what does this all really mean? We've seen that Placenta Previa and Abruptio Placentae, while they both present as terrifying causes of APH, are really clinical opposites in many ways.
They really are antithetical. PP is typically painless, often recurrent, bright red bleeding, involving a placenta that's fundamentally healthy, but just displaced to an abnormal site in the lower segment.
Whereas AP?
AP is typically painful, often continuous bleeding, frequently associated with underlying maternal disease like hypertension. It involves the chaotic premature separation and often systemic pathology DIC, renal failure related to a normally sited placenta failing.
The unifying thread, though, in mastering both these conditions seems to be the evolution and reliance on diagnostics.
Absolutely. We've clearly moved away from relying on dangerous, high-risk clinical judgments, like blindly doing an internal vaginal exam, toward precise, preemptive surgical planning that is driven almost entirely by advanced imaging.
Whether that's transvaginal ultrasound, establishing that critical 2-centimeter rule for PP delivery mode,
Or using color Doppler and MRI to meticulously map the extent and depth of invasion in the accreta spectrum, allowing for that vital multidisciplinary planning before surgery ever begins.
So the ultimate takeaway for you, the listener aiming for mastery, isn't just knowing the difference on paper between PP and AP.
No, it's knowing the required mobilization of resources and expertise that each condition, particularly the severe forms, demands. Complex APH, and especially any case involving suspected placenta accreta, is absolutely not a solo surgical event.
It demands that fully integrated senior multidisciplinary team.
Surgeons, anesthetists, hematologists or transfusion specialists, urologists, interventional radiologists, experienced nursing staff all ready and prepared for the potential for massive blood loss, complex surgery, coagulation failure, and the possible necessity of hysterectomy. Preparation is everything.
This mastery of anticipation and preparation then forces us, I think, to confront a fundamental question that's really shaping modern obstetrics today.
Which is?
Well, early and routine sonography, combined with planned cesarean delivery, has arguably transformed placenta previa from what was historically often a fatal maternal condition into a largely manageable, albeit complex, operative case.
That's true. The outcomes are vastly better.
But that very success, combined with the steadily increasing rates of primary and repeat cesarean sections globally for various reasons, has simultaneously amplified the hidden downstream risk of the accreta spectrum into what some are now calling a genuine epidemic.
It's a major challenge, no doubt. The more scars, the higher the accreta risk in subsequent pregnancies with previa.
So the provocative thought for you to consider is, what ethical, resource allocation, and surgical training commitments must global healthcare systems now make to adequately address this rising tide of morbidly adherent placentas, knowing that the procedures required to manage them safely are some of the most complex, resource-intensive, and blood-intensive in all of medicine? It's a huge question, and how we answer it really dictates the future of maternal safety in the modern surgical era.